Thank you, McGill and Barbara. I am very, very pleased to be here. I want to thank everybody for the invitation because I really get the sense that this is a community. And although my invitation came from an individual, it really was a community decision. What I want to focus on is what I hear and what I've heard over many, many decades, and how do we then prepare others to hear what we have been hearing? So are we listening? There are so many voices in our heads. NLN, Joint Commission, accreditation. I was just sharing with Barbara, our College of Nursing is celebrating. They got all 4 programs accredited and, full accreditation. But I'm telling you, I was there when the faculty was preparing for that, and they were sweating it because it was a lot of work. Not to mention there were finals and grade reports due. And how often are all of those voices very, very confusing because which one's speaking the loudest and which one has the ear at this point in time? I'm not going to go into a lot of detail. I don't like lengthy introductions. My credentials are at the top. That's the end of it. I was recommended by a colleague who actually worked with me when she was a doctoral student on a research grant that we were involved with. And then she went on to invite me to be a co-PI on an award for a PCORI that she was applying for. And so my role there is one of the most unique roles that I have. I can talk about being a patient. I can talk about power of attorney for medical reasons for people. On that award, I'm the patient representative trying to make sure that as we're doing research, we have the patient involved in all phases of the research. Writing the program, submitting it, collecting the data, implementing the findings. That's very intriguing because when some people talk about patient engagement, it's a whole different version. I have had multiple opportunities to learn. When we were talking this morning about retooling, I've been at the medical center for decades and decades. And I always say, we're fortunate enough to be doing really neat things because we're large. But we're also small enough. At one point in time, I shared with McGill, I was doing hospice palliative care and bone marrow transplant at the same time. How many people can say they worked with a patient and family in bone marrow transplant and within 9 months worked with that same family in hospice? I've worked in multiple clinical settings there. I've taught students. I've taught people in the clinical setting. I've traveled the state. And I've done multiple research interviews because my love in research is actually qualitative, getting the patient and family story. I know and I respect that as we work with people, we have to hear the regulatory voices. We would not have a program if we didn't meet regulations. We also have to listen to our students because they have chosen the program based on what they thought we would do for them. And for the most part, they think they know what they want and they're not afraid to tell you. As employees, usually the person has chosen the institution where they're practicing, but not always. Sometimes it's where a job was available. And then they plan on changing. So you're tooling them for a position knowing that they're going to go to pediatrics as soon as they can or whatever the situation may be. And from my cancer experience, I remember how challenging it was to work with new staff nurses who were terrified by the fact that they didn't know all the names of the cancer drugs, the side effects of the cancer drugs, much less that they could kill somebody if they made a mistake. That's overwhelming for new clinicians and experienced ones. Now, as we work with patients, for our researchers and our data people, how much patient-related data do you have? We know the age of our patients, but do we really know what they want? They may or may not have chosen where to receive care. It may be trauma-related. There is no one prototype. Not everybody's just like June or what I expect my family to do. And there are varying levels of knowledge and motivation. So the challenges of this additional voice that we have to reconcile within our systems is the voice of the patient, and I say patient family when I say patient. They travel together in my vocabulary. And we need to hear the patient even when they're very impatient with what's going on because they want it their way. You were talking about being on the stretcher. When my brother-in-law wanted to get out of the recovery area because he wanted to get home to his own bed. He wasn't very patient. And it's like, no, wait a minute, Terry. And their view of the system versus ours, or I really want us to think about in addition, because versus almost sounds oppositional. We are not in an oppositional role with patients and families. We need to get on the same page. That's why we have a job. That's why we have health care. The knowns are, and we've heard about it, it's rapidly changing. Technology. When I was listening this morning, I remembered, and I brought my cell phone up just to remind me to say something. I read a news article about a police force that has a lot of technological savvy people who have communicated with this media and do not know how to carry on a conversation face to face. They're sending their recruits to the shopping centers and making them interview and talk to total strangers because they want the face to face, not the device communication. There are lots of changes in treatments. There are many, many societal characteristics that are changing. In the past, historically, for us older folks, we remember being taught that pain is what the patient told us it was occurring when he or she said it did. And yet we still struggle with pain management and knowing how to go about it. Quality of life in a given situation can only be measured by the patient. How about dyspnea, nausea? Why do we not have better control over those things? Because we can't give it a number from our own assessment. The patient has to. The challenges you know about and you have heard already, I don't need to repeat those, but I want you to know I recognize those because I've been there and I'm still there. When we look at diversity, I want you and I want us to think of a whole new aspect of diversity. When we recruit students and employees into our educational programs, we're looking for what? Cultural diversity, right? And maybe a little bit for age, and yes, gender. But how are we preparing, and the same thing for employees, but how are we preparing those students and ourselves to address a whole new type of diversity in our patients? I'm not talking cultural. I am talking about they come with many different characteristics. Some fully understand their scenario. You heard McGill. He knew what surgery he was going to have and why he needed it. No one had to convince him. He knew what the PACU was, and still there was that concern in his mind of the results. And it's not just teaching them so they understand the scenario. It probably meant worse things to him than it would to some of my family members who wouldn't get it. Comfortability speaking up. You have those people who are not afraid to give you their peace of mind, and you have others who would never argue with a healthcare provider. And yet we wonder why we don't do a better job of changing complex health issues. Have we really listened to the patients, what they need to hear? And then a whole span of experience with technology. You have people who are technologically savvy, and you have others who say, I don't do that. It's one thing to have electronic record and have people able to get into the record once they get home, and another to what you do if they don't have a computer and they don't plan on getting one or using one. Or in my rural state, They don't have service, so it doesn't do any good. I moved to a different housing area in the Omaha metropolitan area, and I lost phone and computer access because I'm in the flight plan for Sac Air Force Base. And so there are no towers beaming the rays to my house. I had to spend the money to get my own extender that fit within my roof. So not everybody has open access. Frequently, it's not just the patient that we're dealing with. Then, as you have multiple family members, the challenges can multiply. My 3 siblings and I don't agree about a lot of things related to healthcare. And when we were working with my parents at the end of their lives, we really had to behave ourselves in front of company. Relationships within the family, who has which role and responsibility. And I think that's especially a challenge if you have a patient and an immediate caregiver in the home that also needs assistance from adult children. Which additional family member is there with each of those home visits? And how often does the scenario change because you have a different person involved? And they have different understandings of the situation and what happens when the person you need isn't there. So your assignment, and I tried to take off on the labeling of the sessions tomorrow, what happens when the disruption you have to deal with is actually the patient and family? They can cause lots of disruptions. You're going to be doing small table discussion. Want you to identify within and across professions at your table what are some of those disruptions and how do you perceive those? How are they similar or different across professions, across care providing situations? How can we learn from those various situations? How can we continue to learn? I am nearing the end of my healthcare career, although I'm on another grant, so not for a while. And what suggestions do you have for enhancing the clarity of this concern when you're teaching someone else, a new clinician in a clinical setting, or a student who may not realize how different patients and families really are? And which disruptions do you find most challenging? So that's my part of the presentation. McGill?
Thank you, Dr. Eilers. That's a lot for us to consider. So we'd like to give each table approximately 8 minutes to consider these questions that June has posed. Those of you that aren't at tables, you can work with each other, and then we'll come back and we'll hear from you all about your thoughts on this.